We're going to move into updates from the three organizations that helped to put this forum on. I'll get started with a data update from CHoSEN Quick. Then we'll move on with Sara Brandspidel, who is the Director of Behavioral Health Initiatives at the Colorado Perinatal Care Quality Collaborative. And then Jade Woodard, who's the Executive Director at Illuminate Colorado and the co-chair of the Support Colorado Steering Committee, will conclude this update. So I'll get started with the CHoSEN update. So the data that I'm presenting includes data up to the last quarter of 2022. This is all substance-exposed newborns captured in our birthing facilities. While we're called CHoSEN Quick, which is Colorado hospitals, we do have hospitals from Wyoming and Montana that also participate in this effort. This report reflects 1,838 substance-exposed newborns and their mothers from our data source, which started in Q2 of 2017. And so I just want to acknowledge and recognize you all who have been at the front lines caring for nearly 2,000 of these maternal infant dyads through this quality improvement collaborative. So thank you. We do collect some basic race, ethnicity, and other sociodemographic information through our work. Shown here is maternal ethnicity and race data. You can see that about 2/3 of our maternal infant dyads, or I would say mothers, because I think the infant race is probably not as accurate as maternal race ethnicity. But about 2/3 are non-Hispanic, and then about 1/3 are Hispanic ethnicity. In terms of race, we have 2/3 being white, about 1/4 sadly are missing. And then the remainder, you see smaller percentages of American Indian, Alaska Native, Asian, as well as Black. So here we see the percent of mothers within our data system that have that are receiving any sort of medication assisted treatment for opioid use disorder. Now, I present this slide with a lot of caveats because the way that we've defined this for our collaborative is if there's any record in the electronic medical records of buprenorphine, Suboxone, methadone. And so you can imagine that there may be some mothers who, in fact, have documented history of being on therapy, but it doesn't necessarily mean, but there's not other substance use that are occurring. And so this is, I think, a very generous estimate of the percentage of women in our cohort that are actually engaged in treatment. That being said, we've never seen a change throughout our collaborative period. There's never been a statistically significant change from the baseline mean of about 50% in our mothers that are receiving MOUD. Here we see the length of stay for all substance-exposed newborns that don't have other conditions that will lengthen their hospital stay. So these infants are 35 weeks or greater and don't have other clinical conditions that impact their length of stay. And so this is not new to many of you, but we saw a dramatic decline early in our work with a decline in the length of stay from about 2 weeks down to about a week. Now, since that week decline, we haven't seen changes, and maybe this is the sweet spot. You know, we were very concerned that continuing to shorten length of stay would actually cause unintended harm, where we shift the burden of care to families that are already stretched or the outpatient providers. And therefore, for now, I think this week-long length of stay feels okay to most of us to date. We do stratify the data by Hispanic and non-Hispanic ethnicity. We would really love to stratify this further by other racial groups, but our numbers are quite small. So in the upper process control chart, you see length of stay for infants born to Hispanic mothers, and on the bottom, the same result for non-Hispanic mothers. The first thing that you'll note is that, let's see if my pointer works. Oh, yes. Then if I move away, you can't hear me. That for the Hispanic group, we did see a decline in the length of stay. We see the decline in the non-Hispanic group. However, that decline for the Hispanic group took much longer, took 2 quarters longer than in the non-Hispanic group. Now, we hypothesize that this may be driven by primary language barriers, but certainly possibly also from bias and discrimination in treating these two groups. Here we see the percentage of opioid-exposed newborns who received pharmacologic therapy. This was one of the most dramatic declines that we witnessed early on in CHoSEN Quick, that when we first started, more than 50% of our opioid-exposed newborns were receiving morphine or methadone, and in a very short span of time, that declined to about a quarter, 25%. Since then, that also has not changed over time. Again, we stratify this by Hispanic ethnicity. And again, you see that while both groups experience this decline in the percent receiving pharm therapy, the Hispanic group takes much longer to get to that new mean of up to 2 quarters. And then among those opioid-exposed newborns who receive pharm therapy, here we're looking at the length of stay for those infants. And you can see that the numbers get real small in more recent quarters because so few of the infants are needing opioid treatment. And so for this group, we saw a decline from about 3 weeks down to about 2 weeks. We have this kind of unusual blip most recently in Q3 of 2022, and that was driven by one infant who stayed a very, very long time. But otherwise, for our infants that do require pharm therapy, their length of stay now is about 2 weeks. We also look at provision of mother's own milk for these infants. And here we see the percentage of substance exposed newborns that are eligible for mother's own milk. We have eligibility criteria based upon the use of illicit substances, some criteria around marijuana use. We can get into that. It's a very heated debate, perhaps at another time. That being said, we haven't seen a major change in the percent of infants that are eligible to receive mother's own milk, which is about 70%. And then here we see among those that are eligible to receive mother's own milk who actually are receiving it. And so, Colorado, as I say every year at these meetings, we are a breastfeeding state. We have the highest breastfeeding rates in the entire country. And that probably applies even for our population that are impacted by substance use. And so we had a baseline mean when we first started that was about 82%. We have seen a decline down to 70% in most recent years. Now, the last couple slides are where things look a little bleaker, and hence the focus of this forum and the work for the next couple of years on transitions, as Mandy so astutely highlighted. This is the percentage of substance-exposed newborns who received, or their families who received antenatal consultations, that is anticipatory guidance about care of their substance-exposed newborn. And you can see these numbers are awful, quite low, sometimes even 0%. Now, we absolutely admit that this might be a data capture issue, that perhaps a consultation occurred in person or over the phone, but was not recorded in the electronic medical record. But I still think it's far from optimal. Here we see the percentage of substance-exposed newborns who received an early intervention referral. We talked a lot about EI at our last forum. We know that substance exposure in and of itself doesn't automatically qualify that family for EI services, but we know that anyone can make a referral. And for these infants that are high risk for a number of reasons, we think that every single one of them should have a referral in place and an evaluation done, and then to determine if they are eligible to receive services. These numbers, we witnessed somewhat of an increase early on from a baseline of 21% to about 35%. And then most recently, it's gone in the opposite direction. So clearly a lot of work that we need to do in how to better support families around the time of discharge. Here we have the percentage of substance-exposed newborns who have a recorded warm handoff to their outpatient provider. Again, certainly could be a data capture issue. It could also be that within closed hospital systems like Denver Health, that perhaps the discharge summary is sufficient, that the PCP can see it. But I would say for these infants and families, a warm handoff is real important. And we saw a moderate increase early on, overall still though far from optimal if we're hovering around 20% of these infants that are receiving a warm handoff. So a lot of work around transitions, hence the focus of that for this particular forum. We're going to talk a lot more about this in the afternoon, but for now, let me hand it over to Sara from CPCQC.
Hi, everybody. Thanks for the opportunity to give some updates from the Colorado Perinatal Care Quality Collaborative. And thank you to Mandy for sort of welcoming all of our hearts into the room. I thought that was really beautiful. So about CPCQC, we are a statewide nonprofit, and we are the Colorado CDC-funded perinatal quality collaborative. So that means we lead collaborative work focused on maternal and infant health around the state. And we are also the AIM state organization, so responsible for implementing AIM patient safety bundles. These are a structured way of improving the processes of care and patient outcomes, evidence-based quality improvement work. We're also the implementation arm of CDPHE's Maternal Mortality Prevention Program and the backbone organization of the Colorado Maternal Mental Health Collaborative. In terms of our reach, about 70% of births in Colorado take place in hospitals that are engaged with CPCQC with at least one of our programs. And so a little more than half of our state's birthing hospitals are engaged with us. We have a number of different programs beyond CHoSEN that we're involved with, including programs that focus on parental engagement in the NICU, perinatal behavioral health, integrated behavioral health, working in Western Colorado with Impact BH, work on primary cesarean reduction and lived experience integration. And I'll go a little deeper into a couple of these. So some updates on a few programs specifically relevant to CHoSEN partners. The Colorado AIM Substance Use Disorder Learning Collaborative, or COAIM-SUD, is sort of our flagship program working with hospitals covering nearly half of all Colorado births. And again, kind of grounding in the fact that the leading causes of maternal mortality in Colorado are suicide and overdose. This work is really focused on establishing hospital guidelines and protocols for screening, brief intervention, and referral to treatment for both substance use disorder and perinatal mood and anxiety disorders in the perinatal healthcare setting. And this is based on an AIM patient safety bundle. And the Learning Collaborative gives teams the opportunity to come together and collaborate to provide the best care for patients and receive that quality improvement support. If your hospital is not involved and is interested in getting involved, you can contact Elena Dillner, whose email is listed here. And we listed some of our upcoming events. These Learning Collaborative events are open to anyone. You don't have to be formally a part of COAIM-SUD to participate in these. And so we have upcoming events focused on best practices to decrease opioid use post-cesarean, the new Moms Plus program, which Mandy mentioned, and I'll talk a little more about, and then medication-assisted treatment quick start training coming up in June. And you can register for all of these on our website. I also wanted to mention Impact Behavioral Health, which stands for Improved Perinatal Access, Coordination, and Treatment for Behavioral Health. And this is a program working to establish a perinatal behavioral health network in Health Statistics Region 12, which is Eagle, Pitkin, Summit, and Garfield counties. And so through this program, we're working really across sectors, to the point that was raised earlier on, like, how do we bridge across sectors to bring outpatient, inpatient care and community-based care together to make sure that our pregnant and postpartum and recently pregnant folks are not falling through the cracks and are getting the care that they deserve. And so we work across these different partners to address mental health concerns, substance use, and social stressors. And look out this summer, we're going to be releasing our implementation guide, which is going to sort of capture what we learned throughout sort of piloting this work in HSR 12. And we'll continue to assess whether there's interest in other counties in engaging with work like this. And if you're interested in getting more involved, you can contact me or Jesse Reeder, whose email is listed here. And then as part of Impact BH, we also are really excited about our new initiative, Moms Plus, partnering with state opioid consultants and the Naloxone Project to bring this program to birthing hospitals across the state. And it really offers tailored technical assistance on medication for opioid use disorder and other ways to connect to treatment and reduce stigma in the birthing hospital setting. I also wanted to mention our FIRST program, which stands for Family Integration to Restore Trust. This is a two-phase community-focused effort to train and then integrate families from diverse backgrounds into leadership committees and work groups within CPCQC, because we know, that meaningful improvements in perinatal health outcomes are really not possible unless we have folks at the table with that lived expertise. If you're interested in learning more about getting involved with that, our info email address is listed here. And then I have to do a shameless plug for our upcoming conference, which will be May 12th, so right before Mother's Day. And there's some flyers out at the check-in table about it. Registration is live on our website. It will be right here on the Anschutz campus. And our keynote speaker is Nina Martin, who's an investigative journalist and author of the award-winning ProPublica series on maternal mortality, Lost Mothers. She has published a lot on maternal health care in America and has a special focus on women's health and racial equity. So we're really excited to have her joining us as a keynote. We're also going to have a plenary session of lived experience experts from Hard Beauty, discussing how stigma showed up for them in their pregnancy journeys and how clinical settings can create spaces of belonging and better support for people impacted by substance use. So I hope you'll join us. We'll be covering sort of building on a lot of the topics that are raised here, and this is a day-long event. And just welcome you to reach out to us if there's any questions or anything that you'd like to learn more about, and thanks for having us.
Good morning, everyone. My name is Jade Woodard. I'm the Executive Director of Illuminate Colorado. So grateful to be here with you all. For those that aren't familiar, Illuminate is a statewide nonprofit focused on prevention of child maltreatment. We've been working in this space of substance use and pregnancy for several years and a part of the CHoSEN Collaborative since its inception. I want to share a few things with you today. As the state, Illuminate, as the statewide nonprofit, serves as our state chapter of a handful of different national organizations. So when we're coming to you today, we're representing different national entities such as Prevent Child Abuse America, Family Connects International, the National Chapter on Fetal Alcohol Spectrum Disorders, and several others. So we are really working to stay connected with the national entities and bring that forward to us in Colorado. You may know April is Child Abuse Prevention Month. We talk a lot about kind of what it means to prevent child abuse in Colorado. And that for us means strengthening families. That means ensuring every family has access to what they need, when they need it, where and how they need it to be well. And so all of us in this room are doing child abuse prevention every day. And so I just wanted to take a moment and acknowledge that and thank you all for your daily work. So as I mentioned, Illuminate does a whole lot of things and through our national affiliations and others. And so this is a really overwhelming slide of logos that I don't expect you to process, but I am going to focus on two of the things that are on this list today. So the first is Family Connects. So we are very excited to be launching this new home visiting program in Colorado. So Family Connects is a national evidence-based model to provide every family, and I say every, truly universal, all families, access to a postpartum nurse home visit. This visit is set to be 3 weeks after birth, and there is absolutely no cost to the family. During the visit, there is a 12-point matrix that is covered by the nurse with every family. So you'll see the top 3 are really more medical in nature, looking at mom's health, baby's health, what are the making sure there's kind of connections for those follow-up visits, whether that's well baby visits or mom's follow-up visit. And then we get into more kind of infant care, safe home, including safe sleep education and other nurse education topics, and then also referrals or supports to families as they arise related to mental health, substance use, or other things that might be happening in that family's household. Intimate partner violence, for example, all of that is covered, and families are connected with resources as appropriate based on their needs. From the research on this, and so this is, as I mentioned, a national program through Family Connects International. There have been 2 RCTs on the model. What they found is that 94% of families had at least one need, meaning what we all know, every family upon the birth of a baby and going home could use a little bit of support. In addition, the kind of magic of the model is twofold. It's really this universality. So not just because every family has needs, but because when we implement universally, we also see significant normalization and stigma reduction of what it means to have a new baby and to have some support at that point in your life. And then finally, there's really this kind of population reach piece of how do we make this across the state of Colorado so it is just part of our standard of care, part of our system of care for families. So some of the RCT results I will share here as well. So more connections to community resources, more positive parenting behaviors, higher quality, safer home environments, higher quality childcare, less reported maternal anxiety. When you look at the 24-month interviews, though, that's where we really start to see the kind of impacts on our larger system. So less maternal reported depression and anxiety, lower rates of CPS investigations, more likely to complete that 6-week postpartum health check, fewer emergency visits for moms, and fewer emergency visits for babies. But those more hospital overnights was actually really saying we're getting babies that need that care in quicker. So couple other things I wanted to mention here. Many of you probably know yesterday marked the end of Black Maternal Health Week. Across the nation, Black women are 3 times more likely to die related to pregnancy-related causes than their white counterparts, which is part of the reason that it is so important that we're really investing in advancing equity initiatives. Prevent Child Abuse America's Executive Director, Melissa Merrick, says, evidence-based home visitation programs are an equity accelerator. And Family Connect's data bears that out. So this 39% lower rates of CPS investigations for white mothers equals a 53% decrease in child welfare investigations for Black mothers. It is really showing across the board the positive impacts for white families, that those positive impacts are even stronger for Black families. So like I said, we're implementing this here in Colorado. We're in 4 counties right now, Eagle County, Boulder County, Denver County, and Jefferson County. I've got the specific hospitals that we're working with. So Boulder County has launched with Boulder Community Hospital, and we'll be working with Avista and Longmont United probably this summer. We'll launch in those 2. Eagle County launched in October as well with Vail Health and is working through with Aspen Valley and Valley View. And then finally, in Denver and Jefferson counties, we'll be launching this summer with Denver Health and hopefully with Lutheran Medical Center as well. So there's a lot moving here. Our goal is to have this be a statewide program that every family gets access to. And so it's going to take us a couple of years to get there, probably some legislation and a whole lot of money, but we're going to make it happen. The other thing I just wanted to quickly mention in my time up here this morning is the work of Support Colorado. Illuminate has the privilege of serving as the backbone entity for Support Colorado. These are our 4 priority areas. These 4 priority areas have remained consistent over the last couple of years, as we feel like there is just so much work to do in these areas. So stigma reduction, warm handoffs, appropriate for today's conversation, fetal alcohol spectrum disorders, and then statewide capacity. Policy fits in with these as well. That's part of our statewide capacity building. So you'll see here those kind of 4 priorities then have multiple work groups that are associated with that. If you haven't heard, on Friday, our governor signed 3 bills protecting reproductive health care access in Colorado. So policy is moving in Colorado to make us a really great state to get pregnant and have babies and get supported after the fact. The magic of Support Colorado really is these 4 buckets though. Data and legislation. We use data and legislation to drive practice and vice versa. Cross-systems collaboration, really with a collective impact approach. Our lived experience experts, you'll hear from Diane in a little bit. She's our chair of our Family Advisory Board for Support Colorado. And then the backbone support that's really able to align and coordinate all the work. So we are grateful to be here with you all. We are grateful to be a part of the conversation and of the CHoSEN work, and would love to have conversations with anyone in this room that would like to learn more about anything I said or Illuminate or anything else. So thank you very much.
God, I hope you all are as excited as I am about what you just heard. There is so much really meaningful work that is currently happening and then upcoming in this space.